Hello everybody and welcome to another episode of the Partially Sighted Society podcast. Today, as usual, I'm joined by Anita Plant.
Morning, Shaun.
Morning. I'm joined by Nickie Johnson.
Morning, Shaun.
And Gary Flack as well.
Good morning, Shaun.
So, today we're going to be talking about quite a wide subject. It's glaucoma. Now, apparently, according to Gary, there's 9 types of glaucoma. But we're going to be focusing on one of the main types, one of the most common types, which is called Open Angle Glaucoma. So, Gary, can you just explain a little bit about Open Angle Glaucoma for us, please?
Okay, Open Angle Glaucoma is actually quite a quiet condition, quiet progression, so it's not always, there's not really many signs or symptoms with it, and more often than not it's spotted by having an eye test where we check the pressure inside your eyes. There are other factors as well, things like family history, so that might actually make you think that there might be more potential for you to have glaucoma. But the open angle version of it is very, very quiet. I've only actually, in 40 years, I've only actually had one person actually come to me and describe their field loss, which they'd already lost. And that was due to glaucoma, and that was actually quite recently, actually. But the rest of the time, it's more spotted via checking the pressures, the optic nerve, and then doing a field of vision test. The other ones are usually a little bit noisier. In other words, you tend to get pain quite quickly. So the things like a closed angle, uveitic. But we're just going to talk about the open angle version of it. Yeah.
Yep. So, what would be the early warning signs that you'd pick up then as an optometrist?
The early warning signs are when we look at the pressure. So quite often in an eye test, you'd have a puff of air against your eye, and that would actually the pressures will be higher than it should be. Sometimes we then get to look at the optic nerve, and that starts to have a change to it. And then the third thing is the field of vision test as well. More recently, we're including things like the OCT, the ocular coherence tomography, to help spot earlier signs that you wouldn't actually spot in even a sight test. So that's kind of one of the advancements.
Excellent. So, what, in the later stages of the progression of this disease, and what would people experience? Would it be like a narrowing of the vision?
Yeah, if I said tunnel vision, that gives you a good description, really. Yeah. So we lose the vision from the periphery through to the centre. If it was the opposite way around, so like AMD, then everything you look at would be black or blurry. Whereas with glaucoma, it's only when you kind of start bumping into things that you realise that you have tunnel vision. So that will be the progression. But there are ways of stopping that progression.
Right, okay, yeah. So we're talking about this narrowing the tunnel vision. Anita, as the low vision assessment officer here, how would you reckon that would impact it? Like Gary just mentioned, bumping into things a lot. But,
Yeah, I think so. One of the things with glaucoma, because it affects the peripheral vision, a lot of people start to experience problems at night. So their night vision would start to deteriorate. So if they're driving, they'll notice that driving is really difficult at night. If they're going out and about, things get dark really quickly, so they'll be tripping, falling over things. So yeah, that's one of the things that people would notice. For that, you'd start to look at using some kind of mobility aid, such as a long cane or so on. If you really, as the field becomes narrower and narrower, you really would begin to need some kind of mobility aid to pick up steps and objects and things in the way while you're walking.
So things like magnification and things like they're not quite suitable, are they?
Well, they would help.
Yeah.
But it all depends on the level of vision, the level of acuity.
Got
So so that's where kind of having a low vision assessment is quite important, because often with glaucoma, and I think you'll agree, Gary, is that the central vision remains intact, so people are still able to read sort of normal size print, and that can cause a lot of confusion, as you can imagine.
The centre part of our vision is the bit that gives us the what is it, whereas the peripheral vision is where are we in space. So we lose that ability to work out where we are, and also the peripheral part of our vision is also what we use for night vision. So again, that's why Anita said that quite often one of the first signs will be actually noticing night vision issues. And you can actually have someone with glaucoma that has a 20/20 vision or perfect vision centrally, but they have no peripheral vision. So it's a kind of hard one because it's not just about vision; it's about the periphery part potentially. Yeah.
Okay, and is this quite a slow decline in vision?
It can be. I mean, particularly with the open angle version of it. Particularly with the first eye, because if you don't know about it, you've not had an eye test for quite some time. It's only when then we sort of go, oh, hang on, one eye is developing it. Whereas then once you know that one eye is developing it, then you would treat the other one to stop it from getting to that same stage.
So I think the thing is, what is really important here is having regular eye tests, because the sooner you pick it up, the sooner you can put the treatment in place, and it stops any further loss of vision.
Yeah, and is it right that there can be a family connection with glaucoma? I've heard that lots of optometrists will ask, is there a history of glaucoma in the family, and therefore they might check for it, maybe do additional tests at that appointment.
So there are two sides to a family, the dad and the mum. And in fact, then the NHS don't actually ask which side of the family the glaucoma is on. But potentially, if you have maybe 2 or 3 people in the family, then it might be that you actually have more chance of having glaucoma. So the tests, it's not that we kind of look twice, if you like, when you kind of have a family history, just to make sure, am I right? Is it okay? Whereas if there's no family history, and you're not seeing any problems, then you would dismiss it. But yeah, there is definitely a family history of it. Yeah.
Can I ask as well, and it's secondary often to diabetes?
Yep, so secondary is to diabetes. So if someone's diabetic, they have more chance of actually having glaucoma as well. So yeah, so definitely there are some conditions that can cause it as well. Yeah.
Keep regular eye tests.
Yeah, another thing we tend to keep touching on, it's a lot of these eye conditions are brought about from lifestyle.
Yeah.
So it's important to anyone listening as well that we maintain healthy lifestyles.
Absolutely.
No smoking, no excessive anything, all the fun stuff you just can't do. So.
Good diet, managing stress, regular exercise.
I'm preaching what I don't.
Not working hard is not one of them. Sorry, Shaun.
I can do that. Yeah. Excellent at that. Yeah. So we talked about this slow decline. We just touched upon that. So Nickie, in terms of this, so someone's been diagnosed with glaucoma. There's somewhat of a pathway ahead, possibly. It's very slow encroaching. How would this impact on them, do you reckon, mentally?
Well, I think there's lots of similarities, obviously, with lots of different sight conditions, not just for glaucoma, but I think the main one for this, I mean, I've heard it described as being sort of the silent thief of the vision. So, it's one of those where the frustration of noticing that actually something maybe you could do a few weeks ago is now becoming more difficult, and that frustration of noticing that something's changed in your vision but not quite knowing what it is, and that sort of process of going to the optician, going to the eye clinic, getting some answers can be scary. Quite scary and stressful for people. And I think since technology, I always kind of go back to this, but because technology has come on, in leaps and bounds over sort of the last years, there's quite a big monitoring process with glaucoma. One of the reasons why we're able to keep it sort of under control, if you like, is because of the monitoring processes in the hospitals that are now put in place with regards to sort of imaging and checking pressures, and lots of sort of virtual glaucoma screening type clinics that people might be a part of. But it can feel quite arduous, for patients who keep having to come back, similar to how diabetics would with their national screening programmes.
That's really interesting. So there's definitely a need to keep going to your appointments as well, isn't there? And keeping track of it can obviously help in more than one way.
And trusting yourself, I think. It's important that, again, I sort of say this, you'll hear me say this quite often, it's so important that you trust your perception of your vision, because we have a clinical aspect, but we also have that functional vision, and only really you know how your functional vision is being affected. What are those things that you do day to day that you're noticing you can't really do well anymore? So do you need to make an additional appointment? Do you need to get in touch with the eye clinic and get somebody to have a look because there's a change? So just trusting your gut that something's maybe not quite right.
And with glaucoma, I see in my clinic, like people will come in and kind of say, I can't see the curbs anymore. I'm falling down the steps, or I trip down the stairs, and you know, can you help me with that? And I think one of the problems with this type of condition is it's an invisible disability. There's no outward sign of any sight loss. And especially for the fact that you've still got quite good acuity, so you might have a situation, and I've seen this with clients, where they've used a long white cane to get onto the bus, and then they get out with their iPhone and read all their messages, and everyone else on the bus is going, hang on a minute, you know, she's faking it. And that's really horrible for the person, because you know, that
it can project, so they end up taking that on. So, you know, not only do you then have other people, so it could be family members, friends saying, well, you could see that, but you can't see that. Actually, then start questioning themselves. Well, why can't I see that? And again, it's that trust in your gut. And it's interesting, Anita, that you mentioned sort of, you know, those aids and equipment, things like white cane, you know, that again in itself from sort of mental health point of view, you know, it's a big step, you know, for someone to kind of start that journey of that white cane training.
I mean, even for people, because we have the symbol of visual disability aids, you know, the badges, the armbands and lanyards and things, you know, even for people to kind of go, oh, okay, I'll maybe think about wearing a badge, you know, it's a big step to do that, because it's kind of acknowledgement of the condition.
And then also allowing other people to see, you know, it's not hidden anymore. So it's making that change mentally to say, I'm kind of owning the sight loss a little bit now, and now I'm ready for everybody else to see that, you know, I have this challenge, this challenge of sight loss. And so, big step.
And they're all tools. They're all just tools to make your life easier.
Yeah, that's right. It shows a lot of bravery of it. You can take that step.
Absolutely, really, really huge amount of courage, and we have to support people to get there. It's not easy for them to do it on their own.
Absolutely.
So, in terms of how we can slow the progression of this disease down, Gary, can you go into a little bit of detail about the possible treatments for glaucoma?
Yeah, I think we've talked about how it affects people when they have quite advanced glaucoma, and that's the white cane, the sort of low vision kind of it. But the important thing here is that if it is spotted early enough, you don't actually have to lose your vision. It's not a fait accompli. It's not this will happen, because if you're using glaucoma medication to reduce the pressure, then that will stop the damage, which will stop progression of the vision. So people do actually have one eye that's developing it, but they can control the other eye, providing that you do use the right medications. And in terms of the general sort of treatment, it's more of an eye drop that helps to reduce the pressure, and that stops the blood supply, or increases the blood supply to the eye, which then stops the periphery dying off. So providing you're using that's okay. That does help. Interesting. I think it's about. I think the last time I looked at the statistics, 30% of people don't use their eye drops properly. In other words, they don't use them. They might think, "Oh, I've not used it for 3 days," and then use it. And the part of that reason is that if you have a headache, you go and take a paracetamol or a Nurofen or whatever it is, because you have a headache. You don't take a paracetamol if you haven't got one, because you haven't got one. So with glaucoma, because it's a quiet condition, you don't have that, I need to go and put those drops in. So it becomes a secondary, and life's busy, and you're busy doing other things, and then you've forgotten, and you're 3 days down the line. In fact, my father-in-law, he actually was notorious for not using his drops. And every time he went to see the consultant, the pressures had gone up, the damage was a bit more, and the poor old consultant gave him another drop, so he was on to 2 drops, and the next time I went, it got up again, and he had on to 3 drops. And it wasn't until we realised that he wasn't opening any of them. It wasn't the fact that he got glaucoma progression, it's the fact that he wasn't actually using the drops. So, that was a big problem for him. So 30% of people don't use it, and it's really, really important to use the drops. And also, they'll tell you to use them at a certain time. So it might be just before you go to bed, and that's because it has the biggest impact on lowering your pressure. And in fact, the pressure inside your eye does vary during the day, so it's higher in the morning and lower in the evening. So the general medication is what they would prescribe.
So the pressure, I mean, there's always like a number, isn't there? So when you go to for a sight test, there's they kind of, for my last sight test, my pressures were 14 in both eyes, and it was like my optician, Gary, was very happy with those. So, what's normal pressure and what's high pressure? What do the numbers mean?
It's quite a vague thing because it's pressures pressures in the eye are from when we either put a probe onto the eye and then measure your internal pressure, or we use a puff of air and we have to average it because it's a screening tool, it's not perfect. But we have this range, and in fact, when it came up with these numbers, I think it was about 2,500 people that did it on, and it was like, well, these have got glaucoma, these haven't, therefore this is the number we'll work with. So it's a bit airy-fairy, the numbers, because also you can actually have things like thicker corneas, or your whites of your eyes, they're clearer or harder, so you actually have higher pressure. Or indeed the opposite, if you've had laser treatment to correct short-sightedness, you'll have thin corneas, and in which case, if you've had that done, 14 actually might be 20, and that's getting close to where we're not happy with it. So I know the answer's not a perfect answer, but there are other factors with it. So 14 is definitely a good one. From a NHS point of view, we do refer people around about the 23 mark. So anything above 23, it's usually a referral. They have got better over the years, such that we used to send people always off to the hospital, and 8 times out of 10 it's like there's a reason for it. So we now do a triage, so you'd actually go to have another check, and then if it's still going up, then they would do some treatment. I know you worked at the hospital, so
I was just going to say with regards
to that.
Well, I was going to say with regards to what you were saying there about, you know, the thickness of the cornea. So there's an additional test that people might, you know, they might not be expecting when they go to the hospital, called a pachymetry, and it's a small probe that will just measure that corneal thickness, and then the doctor's able to use a formula to figure out whether that actually means the pressure is what's being recorded. So that's why some people might have these additional tests.
And in fact, the consultant, when you first diagnosed with glaucoma, they will do this kind of simple maths of saying, okay, you're 28, well, I need you to be 15 or 16, and then that's actually the target pressure that they'll work towards, because if you've got 15, not 28, then you're not going to progress. And that's why quite often we do get this where patients say, I've never seen the consultant since I was initially seen, and that's because that consultant's made a game plan. They've decided on what the pressure should be. They have then, if you like, an army of pre-consultants, if you like, and also housemen and registrars that work with them, and they actually do the pressures and they look at what the target was. And providing the target's within a couple of points of it, then you're doing fine. So this is why you don't always see the consultant. They're usually one person that's looking after you, but he has an army of probably, I don't know, 8, 10 maybe sometimes.
Yeah, I mean,
in which case that's where you don't get to see the consultant.
Absolutely, that's where these kind of almost virtual screening clinics might come into play. So you might come in, you might see a healthcare assistant, you know, you'll sort of have your pressure done, maybe have that pachymetry I talked about. You'd have maybe an OCT, you'd have some what we call fundus images, which are just some photographs of the back of the eye, specifically focusing on the optic nerve and what that looks like. And those monitoring sort of sessions, those monitoring appointments are exactly as Gary says, you know, to ensure that you're on track and that, you know, they can hopefully pick up if treatment's not going well, or whether or not you are or you're not taking your drops very well. You know, so you might find that you have a lot of those screening appointments, you know, just to make sure. We didn't have that years ago, so people would have just lost their vision because we weren't able to pick things up quick enough.
And actually, I think I've said in the past, you know, I spent many years working in South Africa, but I used to see people lose their sight from glaucoma there because the monitoring wasn't good. You know, so unless you're in the private healthcare, you were okay, but if you were under the state, it wasn't great, and people lost their sight from the glaucoma. So it's really important to get the diagnosis and get the treatment, and then it saves the vision. Because I don't see very many people in our clinic. We see a lot of people.
They live well with
glaucoma. They live well with glaucoma.
Don't they?
Yeah, there's no
absolutely.
reason, you know, once you've got diagnosis, there's no reason why you can't.
It's manageable, isn't it?
Yeah, absolutely. But it's always scary, isn't it?
Of course it is. Yeah.
So these are our current procedures in the NHS and possibly private care as well, obviously. But Gary, can you go into some of the more latest advancements into glaucoma? I know you're always on the cutting edge. You're always researching.
Cutting edge, I mean, still is, to be fair, it still's medication that they use as a prime resolve. Prevention's the other one. So if you can prevent it, having an eye test and not actually having it in the first place, that's always better than treating the problem that you've got. There are recent implants that they can insert within your eye, and those implants then dissolve after about 6 months, and they help to reduce the pressure. So with glaucoma, we talk about the pressure being up, but there's a couple of ways of solving that. If you think about having a sink with a plug that's half in, half out, and you start adding water to that sink, it will fill up. So basically you're still producing fluid, which is increasing the pressure, but you're not getting rid of it. So one of the tricks will be to make the opening bigger, to pull the plug out. That would actually reduce the pressure, The other way of doing that would be to turning the tap off a bit. So there's both the same way of doing it. So those medications have a different action, and it depends on how good are you reacted to them as well. So the implant one is to actually just help reduce the flow of the aqueous, and that helps to reduce the pressure. Other things as well, and I haven't got my teeth in, so you'll excuse me when I say this. It's called SLT, which is selective laser trabecular. I can't say it.
That's the Latin name,
Trabeculoplastic.
I always get to
Trabeculectomy,
That's the plastic version of it. Told you I got my teeth in. But we just call it SLT.
That'll do.
It's quite a simple procedure. It's still something that's not particularly used very often, and I am kind of surprised it's not, because it is a laser that you just open up the sort of the sieve, if you like, that's stopping the fluid from getting out. There can be sort of problems with doing that, because you can get inflammation from it, and then it reverses what you've just done, and that's partly why the drops are kind of favoured still. So although there are new things that are going on, it still is pretty much prevention, making sure you don't have it in the first place, and then drops kind of help out from that side of it.
Can I ask a question?
Don't make me say it again.
Oh, go on. Dry eye drops and glaucoma drops, because you know, there's a lot of people will have glaucoma, but they'll have dry eyes as well, and so I know there is a protocol around.
Some of the drops that they give, like Xalatan, tend to give you dry eyes anyway, so it's kind of secondary to using the glaucoma drops. But you're quite right that you can use artificial tears for the dry aspect of things, but you do have to make sure that you have at least half an hour after you've put your eye drops in, your glaucoma ones, before you use the dry eye drops, and at least half an hour before you use the next one. Then that stops them from washing out.
That's quite an important point.
But there's no reason why you can't use them. I mean, ask your consultant when you see them, but there's no reason you can't use those, and it just helps stop the eye from irritable. And there's at least 2 of the medications that are prescribed that tend to give dry eyes anyway. So, you know, if you haven't got dry eyes, I'd be quite surprised when you have got that treatment. So, just using dry eye drops is a good idea.
Is there a drop that gives people really, really long lashes? Because I remember working in the hospital and having to do OCTs on people, and their lashes, like gentlemen, would come in and they'd be longer than mine. I was so jealous. I
know. You have to pay for that.
I know. Lash extensions.
In fact, I think there was a
actually, one of our trustees has got lovely long lashes. He's got
I think one of the American big corporations that do cosmetics, and I'll not mention names, they actually tried to patent it as there's like a 10th dosage of it, because it would make your eyelashes bigger, but there's no downside to having slightly lower pressure, but it's never got past the FDA approval. You can imagine how much money that would have kind of made them.
Actually, that's a question. Okay, so we always talk about high pressure in the eye, you know, it mustn't go high. What happens if the pressure in the eye goes really low?
So if you have a balloon with water in it and let the water out,
deflate.
That's not a good idea. It has to go really, really low. I mean, there's more chance of detached retinas if you have pressures of 4 and 5, but again, probably in a year of seeing people, I see probably one in a year that's where the pressure goes. That's way low. But the drops are not that effective. So if your pressures are tending to be up in the 28s, it's bringing you to 15.
Yeah.
But they wouldn't prescribe it if you were like 10.
Yeah.
But there is actually normal tension glaucoma, which is one of the ones that, of the 9 that we just mentioned, where you can actually still have glaucoma, but your pressure's normal. But that comes back to having an eye test will spot that change in the optic nerve and maybe a field loss as well. But so the OCT is actually a far better tool to spot an earlier version of it, because the field of vision test that we do, which is a little flashy light that you have to shoot them down, that actually if you miss them, that tells you you've already lost your vision. But it was what we had, whereas now we've actually got new technology that spot that much earlier, and it says, hey, hang on, it's changing, but you still have good vision. And that's when you can jump on top of it before it gets bad.
So most optometrists nowadays, opticians, will have an OCT, and
More often than not, I would say,
so you can request if you're not sure how to have that done.
I was also going to say, just from working in the hospital, people used to always say to me, I can see I'm a glaucoma suspect.
Oh, okay.
What does that mean? And I
Yeah,
used
suspect.
to sort of explain it to them.
dodgy.
Yeah, because I remember when I've had my own sort of, eyes photographed, and doctors have said, oh, you've got crowded discs a little bit, or, they're quite small, and, so we're going to just keep an eye on it, pardon the pun, but I think it's more that, actually everybody's optic nerves can just be so different. So if they are, which is part of the reason I think why they do so many different tests, because there's lots of variables to take into account with diagnosing glaucoma.
Yeah, we're humans, not machines.
Absolutely,
So I'm going to pick on Shaun in a second.
Oh dear.
So because we're human, we have variants. So I'm 6'4", I think I'm normal, and Shaun's not.
That's right.
But he is normal, actually.
What's normal?
He is normal. And the thing is that an optic disc that's crowded just means that there's lots of blood vessels coming out of a very small disc. That could potentially be glaucoma, but glaucoma in itself is actually 3 parts. It's the pressures up, the optic nerve has been damaged, and you have a field loss.
Yeah.
So when they talk about suspect, you might have 2 or 1 of the 3.
Yeah.
So you might have naturally 28 pressures, but your optic nerve and your field of vision's perfect, but you're suspect because you've actually got 4 people in the family that have actually got glaucoma. So you're suspect. So you're a bit dodgy. Have I said that to you? That you're a bit dodgy? So that's where that's also called ocular hypertension rather than glaucoma, and that's where the pressure of the eye ocular is higher than it should be. So that's ocular hypertension. So that's another word for being dodgy.
Right. So I think we're just about time to wrap it up, I think. But I'm just going to do a quick fire round, I think, just to end with each of your specialised subjects. Just
No pressure.
Oh my God.
just a quick few lines of advice for people that have just been newly diagnosed with glaucoma.
Okay.
Starting with you, Anita.
Okay, so if you've been diagnosed, don't panic. Use your drops. Get regular eye tests. Functionally, if you're finding that glare is an issue, which sometimes it is for people with glaucoma, wearing a good sunglass or even a wraparound style sunglass that's going to cut out the glare from the top and from the sides. In my experience, people with glaucoma like quite a dark filter. So there's, we've got quite a few of those available here, but do try those, or, reducing the glare by wearing a peak or a cap or something like that. Contrast is really important, so make things easier to see by increasing contrast. If you are finding that you're losing some of your peripheral vision and it's becoming difficult at night, think about bringing in extra light, using a torch, going out with a torch, putting sensor lights at home in those dark areas, to keep the light very constant. Generally good light as well, if you're reading, and I think we've spoken about this before, but that needs to be between the book or whatever you're looking at and your face, so quite concentrated. That will increase the contrast. And if you are beginning to experience difficulty with falling down stairs or bumping into things, you might want to consider investigating some kind of mobility aid, which is either a long cane, and that comes with long cane training, it should do, which is generally available from most sensory support services. You might also want to consider wearing some kind of similar visual disability identifier. And I think, that's probably more about it in my summary. Thank you,
Great.
Shaun.
That's a great summary. Thank you very much. And move on to Nickie, just a final summarisation from you.
Yeah, so if you've been diagnosed with glaucoma, like Anita says, don't panic. You probably will find that the reason you've got to this point is because things have started to change, and that can be quite disconcerting. Talk about it. Don't be scared to reach out to somebody, even if it's us here at the Partially Sighted. We're happy. I'm certainly happy to do some wellbeing calls with people who are worrying about what this might mean for them. Be a little bit kind to yourself. Slow down. I think that's so important. Especially if your peripheral vision has really been impacted. Give yourself some time to accommodate to new environments, just so that you're not you're giving yourself the best chance to not bump into things and knock things over. Yeah, so just starting to really slow down and pace yourself.
Yeah, time's your friend.
Absolutely,
I always say to people,
yeah.
If you're coming from light to dark or dark to light, you might find that adaptation takes a bit longer. So I kind of sometimes suggest to people, if you're, for example, going into a busy shopping centre and you've come from outside into the centre, actually stand away from the door and just give yourself a few minutes just to relax. And if you feel a bit self-conscious, just get a phone out or pretend to look at your watch or something like that, just to give yourself a little bit of time to adapt and sort of scope out the environment before you kind of rush off.
And it is going to be frustrating, it would be for anybody. And we can work with that.
That's an incredible summary. Great, thank you very much. And finally, Gary.
What Nickie said and what Anita said.
Yeah.
I kind of suppose, from my point of view, if the optician's done a good job, then that's why you are where you are, because they've spotted it and referred you. The hospital or the consultant for glaucoma will kind of look after you. So I'm kind of a little bit out of the loop for a while until you need us, or if there's a change in prescription, or just as a regular routine. And there are areas in the country where the sort of screenings put out to opticians. So it depends on the area you're in. I know we're talking about Doncaster and it pretty much is in the hospital, but there are areas where kind of a man in a van comes around to little areas. Make sure you use the drops that they've prescribed for you. And as I said, the early stages are not that bad, providing that you keep on top of it. So it's the later stages which can cause you more problems. So try and keep yourself in the early stages, and that's about it really from my perspective.
Great. So my final quick fire point would be to say, if you've got any questions or concerns about anything you've heard today, you can always give us a call at the Partially Sighted Society. Our number is 01302 965 195. We're open Monday to Friday, 9:30 a.m. to 4 p.m. And more information is available on our websites. That's partsight.org.uk. So thank you very much, everybody. Again,
You're welcome.
episode 4 in the bag. That's glaucoma. So
What's next?
We'll do this again soon.
Thank you.
Thanks, everyone. The information provided in this podcast is intended for general knowledge and informational purposes only, and does not constitute medical advice. The content is not a substitute for professional medical care, diagnosis or treatment. Always seek the advice of your ophthalmologist or other qualified healthcare provider with any questions you may have regarding a medical condition. Do not disregard professional medical advice or delay in seeking treatment because of something you have heard on this podcast. The Partially Sighted Society does not endorse any specific tests, treatment or procedures, and information provided on this podcast should not be considered as such.